Welcome back to the second part. And as Dr. Sumkid said, because this is not taught as much in your country, as I said, it's important that you, let me turn back just a minute. Okay, I want to go back. There we go. It's important that you pick one or two or more of these and review them and use them as review. I was talking to Pan Yupong, who, Pan Yupong used this book in particular and felt it was very helpful for him. So that's not an endorsement, but you might look at that as from that suggestion came from someone who did their medical training here. All right, now. You have my email, okay? I've spoken with several of you directly about some questions that you had, and I didn't have good answers right here, but I have I think I gave out a couple of my cards and encouraged those people to contact me by email, and I will do what I can to find the answers. And so I encourage you, because you have my email address, that if you have some questions, especially about the behavioral science part, or about training, coming to the U.S. and training, please email me, okay? I would very much like to help you however I can. All right, now we're gonna get through as many of the questions and answers as we can, but I'm going to try to slow down. I think I'm trying to rush too much, so I'm going to slow down because I remind you that you have all of this on the DVD, and so you can go back and refresh your memory and review and take a look at it again at your leisure. All right. Now, I'm going to do this, I guess. Now, I think if you don't mind, what I would prefer doing is going through these. We will not go through real fast, but I want to go through them, and rather than have you answer and use the machine to answer, I would prefer that we explore the question, we talk about what is important to pull out from the question, and then we'll look at the best answer, okay? Because I think that will be more helpful for all of us at this point. All right. Oh, good, you can read it. A patient who had a painful bee sting is now afraid of flies and birds. This is an example of, and it gives you basically 5 conditioning or way people become conditioned to different responses and stimuli. Classical conditioning, flooding, operant conditioning, shaping, stimulus generalization. Once again, we have a patient who they were attacked by a bee, and they're now afraid of flies and birds. The best answer for this, and remember, we are talking about the best answer, okay? And that's one of the challenges in the behavioral science area. You have to be you have to think through and be willing to go with what you think is the best as opposed to the answer, all right? So the best answer in this regard is stimulus generalization. So the patient was stung by a bee, but the patient then came to you and said, but doc, flies, flying roaches, I don't like roaches. Who likes roaches? Anyway, yeah, exactly. Flies, butterflies, any insect that fly, even though I know it doesn't sting me, I'm very frightened of. Okay, so there was a specific situation that occurred to that person, and from that, then, they generalized to small flying insects, okay? And what is fascinating for me as a behavioralist when it comes to things like this, if you think about how large most people are compared to a moth, for example, or a fly, we're huge, right? And yet, it is possible that people can become deathly afraid of the things that they know cognitively, they know logically, are not going to hurt them. All right, I was in the clinic 2 or 3 Fridays ago, and one of the nurses came up and started talking about how the nurse was deathly afraid of roaches. Now, I don't like roaches, okay? You know, I don't have roaches as pets. However, roaches don't scare me. But this nurse, who is probably 5'6", 5'7", you know, she's not real small, is deathly afraid of roaches, and that unfortunately does occur. Okay, this question asks, in which of the following is an id function? And when you see the word id, ego, or superego, I hope that you remember Sigmund Freud. Okay, Siggy Freud. Which of the following is an id function? And then you have to remember, okay, what corresponds, what did in Dr. Freud's thinking, what does the id do? What does the superego do? And what does the ego do? So, cognition, conscious, libido, perception, psychological defense mechanisms. Dun, 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 dun. Libido, yes. The id is about being pleased, right? It wants what it wants. It's like, if you think about like a child, a small child wants what they want now, right? Okay. And then ego mediates between the superego and the id, and out of that can come certain defense mechanisms such as cognition. And if you remember, the superego is like the all-powerful mother who tries to remind you what you have to do. All right. This question has to do with the DSM-4. The multi-axial diagnostic system, or the DSM-4, in psychiatric disorders implies that all medical diseases have psychiatric symptoms. All psychiatric disorders are personality disorders. Psychiatric disorders and other diseases can coexist. Psychiatric disorders are complex. So you have to remember, what does the DSM-4 speculate and postulate? Answer is C. Psychiatric disorders and other diseases coexist, reminding us that, as I said, physical and emotional are very much intertwined. Okay? This classification system implies that different axes can coexist at the same time. Okay. Oh, good. You can see this. This has to do, and this is a specific question that you have to know the answer to. You can't intuit. It's not something you can be intuitive about. And it's specifically about information concerning the United States and infant mortality. Which of the following statements is true concerning infant mortality in the United States? A, infant mortality in the United States is high compared to other developed nations. B, prenatal care disappointingly has not been shown to reduce infant mortality. C, the leading cause of infant mortality in the United States is AIDS. D, the mortality rate for white infants is greater than that of black or African American infants. And then E, very few Asian Americans receive prenatal care as compared to African Americans or Hispanic Americans. So what you see in this particular question, they're asking not only about infant mortality across the board in the United States, but they're also then asking you to consider, is there a difference among Anglos, among African Americans, among Asian Americans, or Hispanic Americans? And that's one of the challenges, I think, in the behavioral science area, is that you have to consider, yes, the United States is made up of American citizens and others. At the same time, different subcultures are affected to some degree differently when it comes to their health. Okay? For example, sickle cell anemia pertains only to African Americans, for example, and you just have to remember that and understand that. All right, the answer then would be A. Unfortunately, infant mortality in the U.S. is high compared to other developed nations. I know this statistic is rather old. It's 10 years old. However, in 10 years ago, the U.S. ranked behind 11 other developed nations in terms of infant mortality, which is significant when you think about the healthcare delivery system that we have, and it also tells you a bit about our healthcare delivery system. The leading causes of death in infants is congenital anomalies, respiratory distress syndrome, and SIDS. As I said, I'm not sure if the statistic today would be that low, but it's still too low. For me, certainly for all of us in America, the infant mortality rate is too high. All right, we're going to talk about. There's a series of questions having to do with the same patient and more psychological presentations that they might present to you as a physician. A patient is convinced that an IV injection she received has made her immortal. Okay, now, immortal. One of the things, obviously, when you read a question, you not only have to understand what the broad question is asking you, but in order to understand that, you have to understand the vocabulary and the definition of the words. Okay? And when we use the word immortal, what we mean is that someone will live forever. And unfortunately, in my country, many people want to live forever. And we pursue living forever, okay? That's a side note. So a patient comes to you, and you're examining them, and your patient says, "Doctor, I received an injection last week. I received my flu injection," okay? Because that's big right now, all right? "I received a flu injection, and you know what? I'm going to live forever." And be careful how you respond, okay? Don't go, "Oh my God, that's crazy," all right? Hang on, all right? Not only do you have to appreciate how you might respond initially, but then you have to consider how are you going to respond to this patient in terms of helping her understand that may not be true. And if it is true, you want to know what the injection is, right? Because anyway. All right, so is this an example of delirium, delusion, hallucination, illusion, or reality testing? And the answer is delusion. Delusion is a fixed idea or belief as part of observed reality, okay? So delirium, on the other hand, has to do with how one's sensorium are changed, confusion or disorientation, and hallucination and illusions are, of course, significantly impaired reality testing. So this patient may seem very lucid and very much in reality for the most part, but she has it in her mind that she is going to live forever because of this one injection. And so you're going to have to help her move beyond that thinking. Okay, this is talking about Piaget. And remember, Piaget is focusing on, well, I don't want to give the answer away, sorry. The latest developmental phase, according to Jean Piaget, is A, concrete operations, B, formal operations, C, Oedipus complex, D, preoperational phase, and E, sensory motor phase. The correct answer is formal operations. Piaget speculated that a child, as they're approaching latency age and young teenage years, they're beginning to become more able to abstract and become less concrete. It doesn't happen overnight, but you can see that transition from being a child that sees only things in black and white to an older teenager, young adult who sees things more abstractly and is better able to see things abstractly. Something to appreciate about formal operations, as I said, it's not like a switch. It's a process, okay, and you have to appreciate that. Also, I'm not sure how many of you are familiar or how familiar you are with Dr. Piaget, But I remind you that Dr. Piaget spent most of, at least a part of his life, observing his children as they developed. And from that then came his system of development. And each time I think about that, I think how nice it would have been to be able to work by watching my children develop, but I did not have that opportunity. 32-year-old man presents to a sex therapy clinic with the chief complaint of premature ejaculation, or PE, as it's referred to in commercials in my country. Which of the following procedures is or are appropriate as a physician? If you had a patient, if you had a man that comes to you and says, "Doctor, I'm experiencing premature ejaculation. What do I do? Can you help me?" Okay, and so you begin thinking, okay, what do I need to begin to do to try to help this man? Do you initially order a CBC? Do you then move into a physical examination? Do you suggest that that patient is becoming in need of psychotherapy to talk about their relationships and why they may ejaculate prematurely? Do you help them learn the squeeze technique? Are you a sex therapist? And so do you help them learn the squeeze technique? Now, and then finally, all of the above. Okay? All right, I see some of you, I think, getting the right answer. All of the above. To do a thorough examination. Now, you may not, for example, the squeeze technique, some of you may be aware of it. There are therapists in my country who they primarily, just like I work a lot with children and teenagers and their parents, there are other psychotherapists who do what I do, who work primarily with adults and helping them have better sexual lives, okay? And a squeeze technique is a specific technique that's been developed over it's at least 15 or 20 years old. And it's a technique, it's a behavioral technique and a way of helping someone delay ejaculation. So as a physician, you might not be able to teach them, or you might not want to teach them the squeeze technique, or you might, but certainly you would want to check their CBC and see if there's anything going on that might be causing the premature ejaculation. You would certainly want to do a physical examination to see what their state of health is. Okay, you would certainly want to check and see, are they highly anxious? You know, because we know that can impact sexual performance. If they are significantly anxious and it's been ongoing for some time, you might refer them for psychotherapy. And in that psychotherapy, the therapist might have them begin to engage in the squeeze technique in order to help behaviorally prolong their ejaculation. All right, which of the following is a normal sexual function? Anorgasmia, dyspareunia, masturbation, and premature ejaculation. And if you notice, even someone who deals with these terms, sometimes I don't pronounce them very well. That gets back, do you remember our conversation about world? Okay, practice, practice, practice. All right. So, which of the following is a normal sexual function? It should be C, masturbation. It's considered to be practiced at least universally in my country, although there are still some people who speak out against it, but that's another story. That's another time and place. Anorgasmia, refers to a person that is frigid, a female that's frigid or unable or has the inability or unwillingness to engage in physical intimacy, sexual acts. And then finally, dyspareunia is pain experienced during intercourse. And it can be a true physical condition, it can be a result of a physical problems, or it can be psychological, or both. The people who wrote these questions must have been into sexual dysfunction. 45-year-old woman comes to a sexual dysfunction clinic because of an inability to achieve orgasm. The patient was able to have orgasm in the past, but of late she has lost interest in sex. She comes to the clinic at her husband's insistence. She looks rather sluggish and unkept. A likely diagnosis is A, depressive disorder, B, dyspareunia, C, primary orgasmic dysfunction, D, Turner syndrome, E, vaginismus. A, depressive disorder, with what you were given. The best guess, the best diagnosis at this point would be that this patient is diagnosed, is been depressed, and probably depressed for some time, because her presentation is one of, she seems motorically, maybe even cognitively slow or sluggish, and she seems unkept, which would lead you to begin to wonder what her, as I said, her emotional state is, and certainly depression would be one of those. Which form of dementia is often reversible? With treatment with tricyclics, or the first generation antipsychotics, such as imipramine or serotonin reuptake inhibitors, SSRIs, such as fluoxetine. Alzheimer's disease, Creutzfeldt-Jakob disease, multi-infarct dementia, Pick's disease, and pseudodementia. The best answer is pseudodementia. The other four are basically significant medical conditions and diseases, and are significant in terms of a negative outcome for that patient. Major depression, you must appreciate, major depression can present similarly as dementia, which could involve a lack of concentration, memory loss, loss of mental acuity, etc. Your differential diagnosis would at least initially focus on ruling out major depression. And if you determine that the patient is experiencing major depression, then certainly you would want to consider prescribing antidepressants, such as SSRIs, along with possibly referring for talk therapy as well. And I do a lot of work with children who are depressed, and my psychiatrist friends oftentimes will refer me those children to help them along with SSRIs that they're currently taking. Remember we talked earlier about the different topic concerning substance abuse. The most common type of substance dependency in the United States is A, alcohol, B, barbiturates, C, cannabis, D, heroin, E, tobacco. Tobacco. Probably followed by alcohol. Those two are probably very close. And if you guessed alcohol, you would have been, according to this question, you would have been wrong, but the reality is those two are very, very close. At this point, tobacco is considered the most common form of drug dependency in the U.S., even though, and I remind you, even though we know that it's harmful. Now, you take a puff of a cigarette right now, I'm not going to drop over dead, okay? And that's part of the challenge. However, we know that overall tobacco is very harmful physically. And as we talked earlier, the rate of smoking has steadily decreased since 1964 in the United States. However, recently we have seen rise in smoking among teenage females. All right, this is a question that has to do with physicians and suicide, or I'm sorry, physicians and the use of narcotics and addiction to narcotics. And this is during the career of a physician. And this is one of those answers that you must just know. You can't. It's not something intuitive. But in my country, the likelihood of a physician becoming addicted to narcotics during their career is estimated to be 1 in 10, 1 in 100, 1 in 1,000, 1 in 10,000, 1 in 100,000. And you might be surprised. It's 1 in 100. That's fairly significant. it's not as bad as 1 in 10, but 1 in 100 is quite significant. That physicians in my country can become addicted to narcotics. And part of the challenge, unfortunately, is that sometimes it can be quite some time before a physician is found out to be addicted, okay? And if I'm not sure how you are, but I would not want to be want to be operated on a physician, cardiothoracic surgeon, for example, who is addicted to heavy narcotics, okay? That would not give me good confidence. And so you have to appreciate that 1 in 100 physicians in the United States are addicted to narcotics, and also they're a much higher risk of drug addiction, anywhere from 30 to 100 times greater than the general population. And there are a lot of reasons for that. As I said, that's one of those answers, questions and answers that you just have to know, okay? All right, a man complaining of severe back pain is given an injection of saline. The pain seems to have subsided considerably, okay? I am becoming very, very interested in the connection between mind and body, obviously, because I don't think that there is any distinction, and how we can be affected in multiple ways by things that we think will either work or not work, okay? So in this particular question, you have a man who has severe back pain, and I'm assuming that it's genuine back pain, okay? Because you can also have pseudo pains, can't you? For a variety of reasons. You can have people who think they're in pain and therefore they are in pain. You can have people that fake back pain because they want to get out of work or, you know, whatever. But in this particular question, you have a gentleman that has a severe back pain, and we're assuming that it is in fact genuine, okay? Maybe a slipped disc, or he has a pinched nerve. And he is given an injection of saline, salt water, okay? He experiences that the pain subsides significantly fairly quickly, okay? So you need to begin to consider, why is the pain, what is the reason for the pain relief? Why is this particular individual with genuine pain, back pain, why is their pain relieved, okay? And we can think of a number of things. We know that there is some ability for the mind to convince the body that the pain is not as significant, okay? We also know that pain thresholds differ for individuals, and that can change. But we also know that there are natural pain pain controllers and inhibitors in our body that our body generates. And that's where, for me, the mind-body study of mind-body is very important. The most likely reason for the relief that this patient experienced as a result of the injection of saline is a hypnotic suggestion. And I will tell you that I use hypnotic suggestions, both formally and informally, and they can be powerful. B, secondary gain was achieved, that somehow the relieving of the pain benefited him in some other way, that the pain of the injection caused counter-irritation that in fact helped relieve the pain. Okay, it's like the old joke, if I have a headache, or you come to me and you say, I have a headache, and so I pull out a hammer and hit your toe, okay? All of a sudden, the pain in your head goes away, right? Okay? D, that the saline injection induced endorphins. And E, that the saline injection induced GABA. Okay? And the best answer to this question would be D. It induced the release of the body's natural pain reducer, endorphin. How many of you are into sports like running or weightlifting or pretty significant team sports, basketball, soccer? Okay. One of the things, I run. I love running. And one of the reasons besides using running to keep my weight down, okay, as I get older, I talk about the fact that we develop from birth until death, okay? Now, when I was much younger, I loved basketball. I love playing basketball. And I have this fantasy, even now, at my age, that I will wake up tomorrow morning and I will be 7'6" tall like Yao Ming, and I'll be playing for NBA, okay? That's not going to happen. I'm not crazy. I know it's not going to happen, but I love basketball. I cannot grow 12 inches. It's not going to happen, right? Now, unfortunately, I can grow 12 inches this way, okay? I have to be careful because I can gain weight if I'm not careful. So one of the reasons I like to run is that it helps me either helps me stay at a certain weight or it helps me lose weight when I get beyond that weight, okay? Another reason I really, really enjoy running is that there is, usually within 10 to 15 minutes into my run, I experience the release of endorphins. And it has for me, a lot of good positive effects. Now some of them are real because we know endorphins do a lot of good things for us in terms of relieving pain, helping us to achieve a calm sense, okay? But also, I know that the endorphins are going to be released, and so I'm looking forward to that, so I'm perched for that. But in this particular case, endorphins help once the injection. We know that an injection can prompt the release of endorphins. The release of endorphins then help this patient to feel better in terms of less pain in his back. All right, this is the same man, same gentleman that came to you complaining of severe back pain. The pain seems to have subsided considerably, and the best guess is that there was a release of endorphins that helped. This phenomena indicates that placebos can be effectively used, A, differential diagnostic tool to distinguish between psychogenic and organic pain, B, as a muscle relaxant, C, an opiate substitute, and D, as a research tool. As a research tool. This is the best answer because a placebo is not something you can, in my country, we cannot give placebos as if they are a real drug, okay? And we used to be able to do that a long time ago. A patient would come to you who's complaining of pain, and you, after doing a very thorough examination, determine that the pain is more emotionally based than physiologically based. In years past, you might be able to give them what we call sugar pills, okay, and tell them that the sugar pill will help them, that it's a good medication, and it will help slowly over time relieve their pain, okay? And in many cases, because the patient was primed for the sugar pill to work and take away the pain, it could help, okay? We can't do that in my country anymore. However, we can do that if we use a placebo as in research, okay? And you have, and something to consider, placebo, I would love to have a discussion about placebo and its effect, because any number of things can help promote good physical or emotional health. There's any number of things that can make for negative emotional or physical health, okay? Some of them are more physically oriented, some are more psychologically oriented, but both can have negative or positive results on how we feel. All right, the anal phase fixation may result in, and this is from Sigmund Freud, if you remember his developmental schema, the anal phase fixation may result in dependency, fierce competitiveness, parsimony, and schizophrenia. Parsimony are difficulty as a result of needing to be in control. That's what parsimony, the word parsimony means, someone who has to be in control. Okay? And the anal phase of course, is when the child is developing and going. Sometimes that the phase corresponds with potty training, and sometimes when kids have difficulty going through the potty training phase, they may have some difficulty with control issues. But you got to remember, Sigmund Freud. When I first heard about Sigmund Freud and read about his theories, I was very skeptical. I don't know if you guys know it or not, but Sigmund Freud was one of the originators of hypnosis and psychotherapy. Okay, however, he wasn't a very good hypnotist, and so he then developed psychoanalysis. Okay, because he had a hard time with hypnotherapy. As the older I've gotten, the more I have worked in this field, the more I appreciate Dr. Freud's observations. Okay, they have some truth. It's not 100%, but some of his observations really make sense to me and help me in helping parents better help their children. Okay, and so one of the phases that he addresses is the anal phase, and according to Dr. Sigmund Freud, if a child has difficulty getting through this, or this becomes a major sticking point for the child, then the child may then, from that point on, have some difficulty and need to be in control. Okay, and this is, remember, Erikson, Sigmund Freud, and Piaget, that it's important that you guys take a look at and familiarize yourself once again with their theories. Harry Harlow. How many of you remember the monkey experiments? These are pretty fascinating when it comes to attachment and bonding and parenting. Harry Harlow had used rhesus monkeys, infant rhesus monkeys, and took them away from their mother, and then attempted to see how they adjusted and what they needed in terms of being more better adjusted. Harry Harlow's experiments with the young rhesus monkeys that were separated from their mothers demonstrated that they all died of hydration, all died of dehydration. B, became docile and domesticated. C, chose a terry cloth as a mother substitute. D, had normal sexual development. E, tended to adjust to stress rapidly. The answer is D. These monkeys tended to choose a mother substitute, and the terry cloth provided some familiarity with their biological mom. Okay, and the reason he was doing this is he wanted to try to figure out what helped children attach and why they attached and how they bonded to the parents or caretakers. And if you haven't never read about Harry Harlow's monkeys, you might want to, because it's pretty fascinating. And he found that monkeys that were abandoned by their mothers sought a substitute, a mother substitute, and they would find whatever was closest to that mother substitute. This is interesting. Susan was tending goose eggs when they hatched. The young goslings started following Susan, even when the mother was calling them. This is an example of A, classical conditioning, B, imprinting, C, instinctual behavior, D, maternal bonding, E, operant conditioning. And the answer is B, imprinting. It's pretty interesting in animals. We don't speculate that in humans, we speculate that there is some imprinting that occurs with very young infants, but it's not to the same degree that ducks tend to do or geese tend to do, because they literally, I forget the name of the researcher who did most of the work. Anyway, there's some classic pictures of the researcher walking down a path with about half a dozen little geese following him, because the geese thought that, in fact, he was their mother. And so that's the notion of imprinting and what happens early on, just at a very critical period of time, just after birth. James is a 3-year-old. Okay, 3-year-olds are interesting. Actually, they're wonderful, but they're also challenging. James has a terry cloth blanket that he doesn't want to turn loose of. He likes a terry cloth blanket, even though it's filthy. Whenever it's taken away from him, he throws temper tantrums to get it back. He holds it, he sucks on it, and seems content when he has it. This is an example of castration anxiety, childhood fetishism, codependence, displacement, and transitional object. Some of you, I think I heard the correct answer. Transitional object. Once again, similar to Harlow's monkeys, humans, at least this little 3-year-old boy, took comfort and solace in this blanket. And so while his mother was not always around, he could use it as a mother substitute. And that helps, if you think about it, that also helps in object permanency. Teenagers. Sarah is 15 years old. Usually at this age, one expects her to spend a lot of time with A, mixed group of peers, B, adults, C, animals, D, furry toys, and E, guns. In Texas, it may be guns, okay? No, just kidding. All right, now, this question, first of all, you have to think about what you know about teenagers, okay? 15 years of age is mid-teenage years, all right? You got to remember, developmentally, they are moving into adulthood. They're moving into more abstract thinking rather than less. And you also have to remember what relationships then become important for teenagers. Not exclusively important, but important. Okay? And the answer to this question is A, mixed group of peers. We see 12, 13, 14, 15, 16-year-olds becoming more and more not attracted is maybe a too strong word, but they become more focused on same-age friendships, same-age peer groups. Those are the people that continue to become more important at that time in their life. It doesn't mean that their parents are not important. It just means that their parents are not as important as they used to be. And that's one of the hallmarks of adolescence, is how their relationships then more and more are about peer age relationships, and they're obviously also moving in more to intimate forms of relationships, especially heterosexual or homosexual relationships. All right. I think we have time for just a few more, but I would like to put in a plug at this point. I chose the questions because they tend to, I think, exemplify what you will likely experience on the exam to some degree. All right, and so obviously it's a wide area, like all areas are. But as I said earlier, the challenge with the behavioral science area, I think, is that it does tend to be more specific to U.S. culture or to Western culture, and you just have to know that. There's a lot of crossover. Who is the gentleman that talked about archetypes, overarching things that connect us as humans, whether we're Thai or American or from Cambodia or from South America. I very much believe that there are things that connect us as humans, and yet culturally there are significant distinctions, sometimes glaringly significant, sometimes more subtly significant. And so to do well in this particular area requires that you probably do a bit more study on your own, because as I understand from Dr. Samkid, this is not reviewed as much, even though you guys seem to have a good grasp. Tell you what, why don't we do this? These questions you have the rest of mine. Okay, I know we've only gone through a handful. But part of what I wanted to demonstrate subtly was how you attack a question as well. My guess is you guys have taken many exams, correct? Okay, so you are all good exam takers, right? Very good exam takers? Shake your head yes, because you will become if you are not already. However, something that I must remind you, and this, I have some direct experience with this, not only personally, but also I have people from time to time who come to me and say, I do not take standardized tests very well. Can you help me? And so I work with those, whether it be medical students or law students or teenagers. I work with them to help them. Usually it's the reason that they struggle is because they get anxious and they aren't able to calm down to a point where they can read the questions carefully, think about them in a logical, organized way, and then give the best answer. Okay? So if I can give you something else as you prepare for the USMLE to hopefully come to our country to further your training, and especially as you prepare for the clinical skills assessment piece, because you can imagine, even if you're, we have what's called the OSCEs at our medical school, which is similar. Okay, we have the first and second years get a mock patient, and they have to show that they are learning how to examine that patient. And sometimes, even though they may know how to examine the patient, if they become fearful or become anxious, they lose track of everything that they should know. So my encouragement to you is that you learn how to take a deep breath and calm down before you take pencil and paper test, whether it be multiple choice, or you take or you present for the mock exam and mock patient exam. All right, as I said, okay, it's afternoon. It's after 12. We need to take a break and do lunch. We will be here beginning at 1 o'clock. The child and adolescent psychiatrist, Dr. Decha, will be with us. And then at 3 o'clock, we will have an opportunity to do some mock patient interviews, which I think is going to be exciting and fun. So why don't we do this? Why don't, at the end of that particular piece, if you have any specific questions for me about the behavioral sciences, why don't we ask them then as well, because I'll be a part of the mock patient piece of it, so we can do it all at one time. And so that'll give us about 55 minutes to do lunch and get prepared for the afternoon. Once again, I thank you for your attention, and I thank you for your participating in this conference, and I wish you all the best in the time to come in the future. Thank you.